Hi, so thanks to the IPC and Dr. Gelfand for inviting me. So we're going to see a patient, a pregnant patient, and we're going to start off, these are my disclosures, and we're going to start off with a 27-year-old female patient who's from Monterrey, Mexico. She's unemployed and she came to the clinic for evaluation. She had these lesions on her hands, which were painful, and she had been previously prescribed some medications. She began 8 months prior. She had been treated as viral warts, and then she had seen several doctors. A general practitioner had prescribed a low-potency steroid, and she did not have improvement for 2 months. So she mentioned that these lesions impaired her quality of life, and she came to our clinic. Her past medical history was unremarkable. Only her father had diabetes. So we had a diagnosis of psoriasis. She also mentioned that she had lesions on her genital area, and we ordered a biopsy, some lab tests, and we prescribed topical mometasone and calcipotriol and betamethasone. So these are questions that you will probably face whenever you're seeing a patient who's in their reproductive years. She was recently married, and one of the questions I always ask to my patients is, do you plan on having children? When are you planning on having children? So in order to guide their treatment. So what topical medications could we possibly use on a pregnant patient? So on theory, tacrolimus and steroids at a low dose. They all, of course, they might be linked to adverse events, but they depend on the dose and for how long they have been using it. So if the patient is breastfeeding, please let's advise them to not apply on the nipples. So what topical medications are not recommended during pregnancy? So patients cannot use calcipotriene since it's been linked to enlarged fontanelles and extra ribs. Tazarotene, since we know it's a retinoid, it's listed as category C. Coal tar, phosphodiesterase 4 inhibitors, and tapinarof. And these have been also shown some adverse events in animal studies. So the patient came back with her results. Everything seemed quite normal except for C-reactive protein, ESR, elevated ESR, and a low vitamin D level. The lesions, the biopsy was consistent with psoriasis. She had a DLQI of 15, which her quality of life was severely impaired. And she had a positive quantiferon test, so we sent her to the infectious department where she received treatment for latent tuberculosis since her x-ray, and she had no pulmonary symptoms really, and she continued topical treatments. So one of the questions of this patient, since she was planning on having children the next 3 years, is, will pregnancy make this worse? She was very afraid of getting pregnant. She was an anxious patient, so you can tell your patients that most women, 55% of them will improve, but there's a 23% of women who will have flares. And let's all just know that during pregnancy, the evolution might be very unpredictable. What are the risks in pregnancy due to having psoriasis? So mom can have a higher risk of gestational diabetes, preeclampsia, hypertension, preterm birth, and spontaneous abortion. And we also need to be on the lookout for postpartum depression, since there have been studies that show that definitely these are on a rise in patients with psoriasis. And neonatal risk, low birth weight, small for gestational age, and stillbirth as well. So a patient had her persistent lesions on hands and genitalia. We started treatment on guselkumab, and she continued treatment for 1.5 years without improvement, and then she decided to look for pregnancy, but the patient refused to have any additional medication. What biologics can we use? Well, the FDA-cleared biologic is certolizumab, which is safe, and we can continue adalimumab up to week 28, etanercept up to 32 weeks, and infliximab up to week 20. Most biologics are category B, but there are some biologics that we don't have any data, and therefore they're not assigned, just like the ones that I show on the bottom, brodalumab, ixekizumab, tildrakizumab, and risankizumab. So what are the risks of having had biologic treatment? That's also a question that your patients might ask you before pregnancy. So there's a prevalence of miscarriages and congenital malformations that is pretty similar to what we see in the general population. And there's also a preterm birth rate higher than 9%. And this is not known if is it due to psoriasis or is it due to the biologic. And there are some biologics that we don't have enough data, like the ones listed on the bottom, since there are still ongoing studies, right? So the patient visited us when she was already 20 weeks, and she mentioned that she still had pain. So we talked to her gynecologist. The patient still refused to have any systemic medication. So we applied intralesional steroids. What other options for treatment do we have for these patients? Like, not necessarily for this patient, but for other patients who may have plaque psoriasis or guttate psoriasis, we can apply UVB narrowband, and it is necessary in these patients to supplement with folic acid, since we know that there might be a folic acid drop in these patients. UVA is not recommended, and we need to know that narrowband UVB might not be useful in pustular, scalp, inverse, or erythrodermic psoriasis. So the patient had improvement of her lesions, and they were kept under control with the intralesional steroids. She had a healthy baby boy at 39 weeks gestation, and she breastfed her baby for 9 months. The lesions came back again, and we started guselkumab, and we can see that the patient got better. So what are the risks after the pregnancy of infection for the newborns? There's potentially an altered immune response in patients who continue treatment up to the 3rd trimester. And we also know about this case where a baby had a disseminated BCG infection due to the vaccination, since his mother was treated with infliximab. So it is advised that we wait for live attenuated vaccines until at least 6 months after birth. So this is my patient, and she currently is well. She is not planning another pregnancy for the moment, but I hope that we have some take-home points. The only biologic approved right now is certolizumab. We need to always plan ahead along with our patients and see what their goals for a family are in the future. And let's keep in mind all of the options that are available. So thank you very much.
Thank you, Sonia. We have time for a question or two if anyone wants to come to the microphone. I'll just ask you about in your own community. I'll say in my community, our OBGYNs become much more comfortable with biologics, and so they're usually okay if the patient needs to be on a 17 or a 23 or a TNF even. But it's always shared decision-making. We let the patient know there's some uncertainty, especially in the 3rd trimester. In Mexico, what's it like when you speak to the OBGYNs? Are they okay with biologics? Are they more anxious about it?
Some of them are a little bit anxious, but as the younger OBGYNs are practicing, we usually do not get a lot of resistance from their practitioners, so we start them on certolizumab. Yeah.
Okay. All right. Cheryl?
Just a question about the phototherapy. You said no UVA. Did you mean PUVA or did you mean UVA by itself?
PUVA.
PUVA, yeah.
Yeah, so you left it. It was a silent P.
Yeah, yeah, and it's an interesting. There is one study that UVB is associated with a reduction in folic acid levels. It's really hard to know what to make of that, but I do generally tell the patients, okay, if you get phototherapy in pregnancy, make sure you supplement your folic acid, which they're supposed to be doing anyway, but it's a little pearl. Okay, thank you so much, Sonia.